We start in three, two, one. Please go ahead.
Well, very good evening to all of you, and good morning and good afternoon to all others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Amy D. Shapiro from Milwaukee, Wisconsin, USA. And she's going to lecture us on the use of prophylaxis in the treatment of rare bleeding disorders. This webinar is brought to you by Mumbai Hematology Group, supported by Novo Nordics, Natco Oncology, Lucian Life Sciences, and Nirvin Life Sciences, and managed by Perfect Square. I thank Team Novo Nordics, Lucian, Natco, and Nirvin, Mr. Yash, Mr. Kalpesh, and the Team Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speaker for the day, Dr. Amy D. Shapiro from Milwaukee, Wisconsin, USA. All our discussants who are themselves very eminent hematologists, and you participants for spending your Saturday evening, morning, or afternoon from whichever part of the world you're logged in. Tomorrow, that is Sunday, 11th August 2024, from 11:30 a.m. Indian Standard Time, we have Dr. Reena Nair from Tata Medical Center, Kolkata, speaking to us on bispecific antibodies in lymphoma. Let me introduce our discussions for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. Aishwarya Raj from Shelby Multispecialty Hospital, Ahmedabad. Dr. Akanksha Garg from Zydus Hospitals and Zydus Cancer Center, Ahmedabad. Dr. Amber Garg from DKS Hospital, Raipur. Surgeon Commander Dr. Arun V.A. from INHS Aswini Kolaba, Mumbai. Dr. Avinash Kumar Singh from Paras HMRI Hospital and Patna Hematology Clinic, Patna, Bihar. Dr. Bipin Kulkarni from KEIM Hospital Campus, Parel, Mumbai. Dr. Deepak Charles from Aster Medcity, Kochi. Dr. Deep Jyoti Pusti from Institute of Medical Sciences and Some Hospital, Cuttack. Dr. Dhyaneshwar Upase from New Life Hematology Center, Wakad, Pune. Dr. Fahima Hassan from United Institute of Medical Sciences, Prayagraj. Dr. G. Vikram Kumar from ESIC Medical College Hospital, Hyderabad. Dr. Geeta Vidyadharan from Karkinos Laboratory, Kochi. Dr. Gopinathan M. from Chennai. Dr. Neemia Thanda from North Okkalapa General Hospital, Myanmar. Dr. Kapil Garg from SMS Medical College, Jaipur. Dr. Karthik Kumar from All India Institute of Medical Sciences, AIMS, Rishikesh. Dr. Kunal Chatani from Nagpur. Dr. Mallikarjun Kalashetty from Comprehensive Cancer Center, Manipal Hospital, Bengaluru. Dr. Mopali Ghosh from IHTM, Kolkata. Dr. Narendra Kumar Chaudhary from AIMS, Bhopal. Dr. P.K. Sasidharan from Government Medical College, Kozhikode. Dr. Radhika KK from Nizam's Institute of Medical Sciences, Hyderabad. Dr. Rucha Patil from KEIM Hospital Campus, Parel, Mumbai. Dr. Shruti Toshniwal Mantri from Shri V Care Clinic, Aurangabad. Dr. Siddesh Kalandri from Blood Care Hematology Clinic, Nashik. Dr. Sudhir Mehta from SMS Medical College, Jaipur. Dr. Tulika Sheth from AIMS, Delhi. Dr. Varun Bafna from Dr. Bafna Star Clinic and Hospital, Kolhapur. Dr. Vishwadip Khushu from AIMS, Nagpur. Dr. Neemon Ten from North Okkalapa General and Teaching Hospital, Yangon, Myanmar. Dr. Yogalakshmi Shiva Prakasam from Star Hospitals, Hyderabad. Dr. Yogendra Singh Yadav from AIMS, Bhopal. Now it's time to introduce our guest speaker for the day. We are with us, Dr. Amy D. Shapiro from Milwaukee, Wisconsin, USA. Dr. Amy Shapiro is MD, is Medical Director, and is CEO of Indiana Hemophilia and Thrombosis Center in Indianapolis and Adjunct Senior Investigator, Clinical Track at the Varsity Blood Research Institute in Milwaukee, Wisconsin. She completed her medical training at New York University School of Medicine in New York City and her pediatric internship, residency, and fellowship in pediatric hematology oncology at the University of Colorado Health Sciences Center in Denver. She's author as well as co-author of more than 320 journal articles, abstracts, and textbook chapters clinically focused on improving treatment for people with rare bleeding disorders. She has served on the National Hemophilia Foundation's Medical and Scientific Advisory Council, as well as several boards for the National Institutes of Health in the Data, Safety, Monitoring, and Clinical Trial Review. As one of the founders of the American Thrombosis and Hemostasis Network, that is ATHN, Dr. Shapiro served as co-chairman of the board of directors and remains active on various ATHN committees. She was honored as Physician of the Year by the National Bleeding Disorder Foundation and most recently received their Leadership in Research Award. Among other accomplishments, she was presented with a Distinguished Hussier Award in Indiana. And today she's with us and she's going to lecture us on the use of prophylaxis in the treatment of rare bleeding disorders. I stop over here. Very well. Thank you so much. Over to you, ma'am.
Thank you very much. That was a very kind introduction. I would like to just say that I'm actually from Indianapolis, Indiana, although my academic appointment is in Milwaukee. So I live in Indiana, but it's not so far from Milwaukee. So a very esteemed audience today. So I'm humbled to present to you rare congenital factor deficiencies and the use of prophylaxis. I'm going to review the prevalence and symptoms of these disorders, the management of bleeding, go over some specific deficiencies, the use of prophylaxis, spend a little bit of time on women with rare bleeding disorders as a special population, and then touch on looking ahead what we might hope to accomplish going forward. So starting with prevalence and symptoms.
Full screen mode, ma'am, please. The presentation in full screen mode.
Oh, I'm so sorry. Here you go.
Yeah.
Can you see it now?
Yes, ma'am. Perfect. Absolutely.
I'm sorry.
Yeah.
Apologies. So now looking at the prevalence of these disorders, there's no international universally accepted definition of rare disorders in the United States or throughout the world. And despite this, the definition in the EU, the US, and Japan are similar, and they range from 5 cases per 10,000 in the EU, no more than 200,000 affected in the United States, and less than 50,000 affected in Japan. And if you calculate this, the prevalence to meet this definition in these areas translates to about 1 case in 1,500 to 2,500 population. If you think about hemophilia A, the prevalence here is about 1 in 5,000, and hemophilia B is 1 in 30,000. So clearly these disorders meet the definition of rare disorders for all of these countries. And they actually make up about 95 to 97% of all individuals with rare bleeding disorders. But the remaining 3 to 5% of rare bleeding disorders include a large number of coagulation disorders, clotting factor abnormalities, which are either qualitative or quantitative, and specific platelet disorders. Some of these are listed over on the right with an estimated prevalence per million population for each of these disorders. If we look at the overall world population percentage by geographic area, this is represented on the left side of the screen here. And it reveals that Asia demonstrates about 51% of the world population, Europe about 13%, and Africa 11%. According to the World Federation of Hemophilia International Survey of Rare Disorders, the percent of identified cases per geographic area is shown here on the right, and it's not consistent with the overall population. The majority of patients with rare disorders were identified in Europe, 52%, the Eastern Mediterranean, 14%, and North America, 13%. Now, this may be an issue of either identification or reporting to the World Federation system. But overall, rare bleeding disorders remain underdiagnosed or underrecognized in many parts of the world, highlighting the need for further efforts to assure that we identify these patients and provide them access to care worldwide. Now, just to show that the world population underreporting is not just in Asia or other parts of the world, I'm going to show you some data from the United States also showing that we underreport these disorders as well. In the United States, we have a data collection system through the American Thrombosis and Hemostasis Network, which is a national agency through which federally recognized hemophilia treatment centers submit data. On the left-hand side of this slide shows you how the United States is divided into different regional networks for collecting and submitting data. And on the right-hand side shows you the actual presence of these federally recognized treatment centers in the United States. Now, there's two systems for reporting patients at federally recognized treatment centers in the US, and I'll show you these. One is called the population profile. This is general data of all individuals treated at each treatment center, and no consent is required for this because it's absolutely aggregated, anonymized data. It includes age, sex, diagnosis, a specific deficiency, the level, inhibitor status, and a treatment regimen. Rare bleeding disorders are included in this population. Now, the second form of data collection is something called the registry or community counts. This is another Athens system, and it's connected for the Center for Disease Control in the United States, and it's a national surveillance system. The community counts requires participants to agree to non-identifiable data collection. So it's an assent, but again, their identity is completely protected. They're assigned an identification number, but it does report more granular or specific data for each of these patients. And this, again, it includes the basic demographics like diagnosis, age, sex, treatment, but also includes joint range of motion, the number of bleeding events, and it's collected over a retrospective 12-month period of time from the date of entry. And again, rare bleeding disorders are included in this more detailed registry. So Dr. Shweta Gupta from our center conducted a study using the data from these national systems, and she was looking at the status of reporting of rare bleeding disorders within these systems. And we performed an analysis for rare bleeding disorders comparing the population treated in each HTC network, which is the population profile, which is all of the patients because it doesn't require consent, to the expected prevalence in the country. So here we took the published global prevalence, and then we took the estimated US cases based upon that prevalence, based upon the population in the United States. And then we looked at the population profile, which is again, all of the patients registered in the treatment centers through the US, and looked at the reported cases. And then we looked at the observed US prevalence and calculated the observed versus expected number of US cases in the US. And what we found is that the estimated cases that the prevalence of RBDs in the overall 2017 US population, the cases in the network were lower than expected for factor 1 or fibrinogen, factor 2, 10, combined 5 and 8 deficiencies by 36%, 61%, 75%, and 94% respectively. And they were higher than expected for factor 13, factor 5, factor 7, and factor 11 deficiencies by 7%, 14%, 33%, and 185% respectively. So you can see that even in the United States, we are underreporting rare factor deficiencies, which may be due to a variety of issues. They may be underrepresented in the hemophilia treatment centers. They may not be recognized, they may not be referred, or they may not be entered into more detailed data collection. So the community counts data is, again, as I said before, consented and far more detailed reporting for bleeding episodes and associated issues. And the far less number of individuals with rare bleeding disorders are included in this system. And so we took the proportion of rare bleeding disorders reported by the population profile within the treatment centers, and we looked at who was enrolled in the registry. And you can see that overall in the treatment centers, only about 11% of individuals with rare bleeding disorders were approached or consented or agreed to participate in the registry. And I think for the most part, this may be an issue not with consent, but with approach for the treatment centers to these patients to collect this more granular data, which is really needed for these patients for us to understand these bleeding disorders and their natural history and their outcomes. So let's go for a bit discussion of symptoms and severity categories. Overall, the most typical bleeding symptoms observed in rare bleeding disorders include mucosal tract bleeding, excessive bleeding with injury or interventions, bleeding during labor and delivery in women, and bleeding from circumcision in males. However, some of the deficiencies have specific hallmark bleeding events, including central nervous system, umbilical cord, hemarthrosis, and tissue hematomas in disorders including fibrinogen, factor 7, factor 10, and factor 13. GI bleeding may also be seen in factor 10 deficiency, and spontaneous abortion is observed in afibrinogenemia and factor 13 deficiency, and we'll touch upon that when we talk a bit more about prophylaxis for some of these disorders. Overall, the diagnosis criteria for rare bleeding disorders, the best data is probably obtained from the Rare Bleeding Disorder Database and the Prospective Rare Bleeding Disorder Database, the RBDD and the Pro-RBDD, that was run through Milan through Dr. Flora Pavandi's center. And through this data collection, which was worldwide, we've really been able to advance the knowledge of our diagnostic criteria. So unlike hemophilia, where severity categories are severe, for example, less than 1% or less than or equal to 2%, moderate is up to 5%, and mild above that. If you categorize these into severe, moderate, and mild for these rare disorders, the level of each of these clotting factors needs to be tailored for what's clinically observed for the types of bleeding episodes that we actually see in these deficiencies, and it's not the same category. So here is just an overall slide looking at severity categories for these different deficiencies and what would constitute a level that might make you asymptomatic. But I'm going to delve a bit more into this in the next slides. So this slide details the laboratory abnormalities and the common bleeding symptoms observed in what are considered severe rare bleeding disorders. Please note that severe here again is defined differently for some of these disorders based upon the observation of the clinical symptomatology. So the levels are quite different. The hallmark or the more common bleeding symptoms are highlighted for each in blue. So for example, in fibrinogen deficiency, you can see umbilical cord and miscarriages as a hallmark bleeding episode. In factor 2 deficiency, you see subcutaneous muscle hematomas and hemarthrosis. In combined factor 5 and 8, you may see bleeding with circumcision. In factor 10 deficiency, you see umbilical cord, hemarthrosis, and GI bleeding. And in factor 13 deficiency, you see umbilical cord, central nervous system, miscarriage, and intraperitoneal as hallmark bleeding episodes. But again, you see many different bleeding episodes in these deficiencies and not listed here. And one of my colleagues, we were talking before the talk began, was alpha-2 antiplasmin, and in that deficiency, you do see central nervous system bleeding in the newborn period as well. Looking at the more moderate and mild and asymptomatic definitions, here are the levels that are generally utilized for these categories. And I think this is very interesting. So for example, if you look at factor 13 deficiency, a moderate level is considered less than 30%. And these individuals actually experience bleeding symptoms. So before, when we were using the urea clot lysis assay for detection of factor 13 deficiency, we were really only picking up severe deficiencies, and we were missing all of the patients who had a more mild or moderate phenotype with higher levels and still continued to bleed. So now with a better assay, the barochrome assay, looking at actual percent of factor 13, we can pick up these individuals and classify them better. There are other rare factor deficiencies. I call them the rarest of the rare. These are very uncommon, and they include combined vitamin K dependent factor deficiency, where less than 50 families are reported, as well as alpha-2 antiplasmin and plasminogen activator inhibitor 1 deficiency. Their reported bleeding symptoms and the coagulation laboratory findings when abnormal are listed, as is their inheritance pattern and potential treatments. Now, one thing I'd like to point out here is that in plasminogen activator inhibitor deficiency, what's listed as a diagnostic criteria is an absent to low normal antigen with an absent to low or an absent pi1 activity. Now, the problem with this is that the pi1 activity assay is not very good. And actually 0 is included within the normal range. So you can be a normal individual without bleeding and have what's classified as an undetectable pi1 activity. So that assay needs to be improved because identification of these patients utilizing that assay leads to over-identification and putting people into that category when in fact they may have a different bleeding disorder. Some other very, very rare bleeding disorders, which are interesting because these are autosomal dominant, not autosomal recessive. And these include factor V short, factor V Amsterdam, and East Texas bleeding disorder, and tissue factor deficiency. And again, these are autosomal dominant. So these are interesting when you find a family that has these types of bleeding symptoms that are autosomal dominant and they have a very rare disorder and they haven't been picked up through most of your normal coagulation assays. You can sometimes look for these through more specific assays to find them and then to categorize them and use appropriate therapy. It's interesting that some heterozygous who carry these deficiencies with levels greater than 30% may exhibit symptoms as well. And what we've seen is mucocutaneous bleeding, bleeding during surgery, menorrhagia, spontaneous abortion, and bleeding during vaginal delivery have been reported in about 20% of women with all types of these deficiencies who carry them. Post-traumatic hemarthroses and hematomas are rarely reported in factor 7 and 10 deficiencies with these levels. So I think the predominance of individuals you see in this range who have symptoms tend to be females, but it's not totally attributable to just female sex. So some males in this area have bleeding as well. So let's switch to management for a bit more detail here. And what we base our management on is the severity of disease, the type of bleeding, the factor residual activity in the patient's plasma, and the factor half-life of the replacement product that you're utilizing. Overall management data comes from single or few combined center experiences, which is due to the rarity of these deficiencies and the consequent absence of randomized controlled studies that limit recommendations to basically expert consensus rather than evidence-based guidelines. So the grade of evidence for what we really base our therapy on is fairly low, which is considered 2B or 2C. That's low or moderate, but it's the best we have because conducting randomized trials would be not feasible in populations where these bleeding disorders are so uncommon. So Dr. Pavandi's work through the ENRBD, this was funded through the European Union to address the gaps of clinical manifestations, treatment, and the genetic basis of rare bleeding disorders. The project involved the participation of 13 European partners who retrospectively collected data on 489 patients affected with different types of rare bleeding disorders over 3 years. The relationship between laboratory phenotype and bleeding severity in the patients was explored, and the clinical bleeding episodes were classified into 4 categories according to severity. So they were classified as being asymptomatic, grade 1, which was bleeding after trauma or in association with medications that affect the coagulation, such as antiplatelet agents or anticoagulants. Grade 2, which is spontaneous minor bleeding, including bruising, ecchymosis, minor wound, oral cavity, epistaxis, and menorrhagia. And grade 3, which is spontaneous major bleeding, including hematomas such as intramuscular requiring hospitalization, hemarthroses, central nervous system, GI, or umbilical cord bleeding. They did a linear regression analysis, which revealed that fibrinogen, combined factor 5 and 8, factor 10, and factor 13 had the best correlation between the activity level and the clinical severity, as denoted by the red arrow on the left, these over here. Factor 5 and factor 7 deficiencies showed a good correlation, shown with the green arrow, whereas factor 11 deficiency showed no correlation. For factor 2, the number of patients was too small to draw any correlation. In this table, the actual values from the linear regression are demonstrated. If you look at the last 4 columns, they tell you the factor level associated mostly on that line of correlation with certain bleeding types. For grade 3 bleeding, or the most severe, the values were mostly negative for some of the factors, which could be interpreted as probably 0. So this study remains the first to classify rare bleeding disorders on the basis of clinical and laboratory parameters, and to highlight significant correlations between the laboratory phenotype and the clinical bleeding severity. The main limitation of the study is that it was retrospective in nature of the data collection, and the observed heterogeneity between the different rare bleeding disorders really underscores the need for prospective data gathering that allows adequate assessment of each individual disorder, which Dr. Pravandi's center is continuing to try to perform. So when choosing how to treat or replace a specific bleeding disorder, you use a hierarchy based upon the safety, of the replacement product and whether a recombinant or a specific single plasma-derived concentrate is available, which should be priority choices. Adjunctive treatment should always be considered for minor and mucocutaneous bleeding events, but remember that antifibrinolytics such as tranexamic acid are contraindicated in renal tract bleeding or in cases with a high thrombotic risk, which can be seen in certain clinical circumstances or with specific deficiencies such as afibrinogenemia. When using FFP, the volume overload or reactions must be considered. And when prothrombin complex concentrates are utilized, it's important to be aware that they've been associated with both arterial and venous thrombotic events when higher repeated doses are utilized. Here are listed each specific factor and its plasma half-life, a recommended trough level to prevent bleeding episodes is listed on the right from the European Network on Rare Bleeding Disorders, and comparing this to what was previously reported as a recommended trough, you can see that these are different now compared to what was reported previously, especially for factor 13. Available therapeutics for treatment of rare bleeding disorders vary throughout the world, and choosing a product should be based upon availability and safety, with attention to use of a specific factor concentrate or when a recombinant therapy is available as a priority agent. Unfortunately, few recombinant products exist for these rare disorders, except for factor 7 and factor 13. However, plasma-derived specific concentrates do exist for fibrinogen, factor 10, and factor 13 as well. So let's talk about some of the specific deficiencies we've reviewed. And I've grouped fibrinogen and prothrombin or factor 2 deficiency together because both of these require an antigenic measurement to differentiate a complete absence, meaning A, versus a dysproteinemic state. Abnormalities of fibrinogen include quantitative deficiencies such as complete afibrinogenemia or decreased antigen and activity in hypofibrinogenemia, and qualitative abnormalities with discrepant antigen and activity, such as dysfibrinogenemia with a normal antigen and a decreased activity, and hypodysfibrinogenemia with a decreased antigen as well. It's important to know that the Klaus method for measuring fibrinogen is not accurate below 60. And so oftentimes you get a level of 60 or less, and it's very difficult at that point to know exactly what you're looking at. And so more advanced sensitive testing and genetic testing can sometimes be used to help you differentiate these patients. The most severe form is afibrinogenemia with symptoms including mucocutaneous, soft tissue, joint, and umbilical stump bleeding. And there is an associated risk of thrombotic events in afibrinogenemia, so care and treatment are tailored. Hypo and dys usually are associated with a more mild bleeding tendency. Prothrombin deficiency is a very rare bleeding disorder, and the types include hypoprothrombemia with a decreased antigen and activity, and dysprothrombemia with a normal antigen but a decreased activity. Aprothrombemia is not compatible with life, with partial embryonic and neonatal mortality demonstrated in a mouse knockout model. Severe patients are those with levels less than 5% and have post-injury and mucosal bleeding, hematomas, and hemarthroses. Patients with level greater than 5% or with dysprothrombemia usually remain asymptomatic. Both FFP and PCC can be effective to reduce or prevent breakthrough bleeds, and the literature reports large variations in dose and interval. Prophylaxis is recommended for those with a history of severe bleeding or with a prothrombin level less than 1%, using PCC 20 to 40 IU per kilo per dose, adjusted to maintain a trough of greater than 10% as the recommendation. Factor 5 deficiency is divided into two types. 75% of cases are type 1 with a decrease in antigen and activity, and 25% are type 2 with a normal antigen and decreased activity level. Approximately 80% of factor 5 circulates in plasma, with the remaining 20% found in the alpha granules of platelets. Studies on human megakaryocytes have provided evidence for both endogenous factor 5 synthesis and secondary endocytosis of plasma factor 5. Because of this, platelet transfusions may also be used with particular attention to the risk of alloimmunization. Symptoms usually develop within the first 6 years of life and may include epistaxis, post-op, and oral bleeding. Later in females, menorrhagia is noted, and in more severe deficiencies, umbilical cord and muscle bleeding and hemarthroses may occur. Combined factor 5 and 8 deficiency is associated with genetic variants in the lectin mannose binding protein LMANI1, previously called ERGIC53, and multiple coagulation factor deficiency 2, MCFD2, both of which encode proteins involved in intracellular transport of factor 5 and factor 8, which are related proteins. This disorder is usually associated with concomitantly decreased levels of both coagulation factors, ranging from 5 to 20%, with concordant antigen and activity. The bleeding tendency is mild to moderate. Regular prophylaxis is usually not required. Interestingly, the two-factor deficiency is not additive to the observed clinical bleeding phenotype of each one at its level itself. However, when bleeding does occur, treatment for both factor VIII and factor V deficiency may be required with DDAVP and recombinant factor VIII and FFP as needed based upon the bleeding event. Women may experience menorrhagia and bleeding with delivery and in the postpartum period. And for some of these individuals, use of more aggressive therapy may be warranted. Factor VII deficiency is the most common of all rare bleeding disorders, representing about 30% overall. The factor VII deficiency has a weak association between the residual coagulant activity level and clinical bleeding. Interestingly, a survey of about 499 heterozygous patients with one allele affected with factor VII alteration revealed clinical bleeding in about 19%. Symptoms may include epistaxis and menorrhagia. More severe symptoms include hemarthrosis and CNS bleeding. CNS bleeding was reported to be as high as about 16 to 18% in a series of 28 patients. Currently, recombinant 7A is utilized at a much lower dose than is used for inhibitor treatment in hemophilia. It's very effective, but the limitation is the short half-life. Therefore, there have been some efforts to develop longer lasting factor VII concentrates as noted here, but none have reached the clinical area at this time. Factor X deficiency represents one of the more severe rare bleeding disorders, and levels less than 10% are associated with severe bleeding evident early in life and include umbilical, central nervous system, and GI bleeding. Also, epistaxis and menorrhagia are reported. Individuals who are heterozygous have reported postpartum bleeding requiring transfusion. A plasma-derived factor X concentrate is available and has shown excellent efficacy for treatment of bleeding, perioperative hemostasis, and its use in prophylaxis as well. Factor XI deficiency is the second most common rare bleeding disorder, accounting for about 26% of all deficiencies. The prevalence ranges from about 1 per million population to 1 in 450 in Ashkenazi Jewish populations. Clinically, patients with factor XI deficiency are very heterogeneous in terms of their bleeding symptoms. Patients with a severe disorder are at higher risk of bleeding, but some remain completely asymptomatic. Patients with a partial deficiency may bleed after trauma or surgery. The ENRBD found that no association in 133 patients between the phenotype and the residual coagulant level. So we can't predict bleeding based upon the level alone. Bleeding is more common when injury or invasive procedures are performed in areas of increased fibrinolysis, with the risk ranging from about 1.5 to 40%. Recombinant factor VIIa at very low doses has been reported to be successful in treatment and prevention of bleeding when required, which is, I think, very interesting and can be helpful as an agent to treat these individuals, especially because FFP or factor XI concentrate, FFP may be very difficult to use, and factor XI concentrate in some instances can be associated with thrombotic episodes. Factor XIII is a transglutamase that circulates in the plasma as a heterotetramer of 2 catalytic A subunits and 2 carrier B subunits. Factor XIII is active after release from the B subunits, and most factor XIII deficiency is actually due to a deficiency in the A subunit, but it does need to be defined in terms of use of treatment because the recombinant factor XIII concentrate contains only the A subunit. Symptoms include delayed wound healing, recurrent spontaneous miscarriage, soft and subcutaneous tissue bleeding. Central nervous system, spontaneous hemorrhage, and umbilical cord bleeding are hallmark bleeding events that often occur very early in life. There's a strong correlation between clinical severity and residual activity level. Early prophylaxis is recommended, and patients with levels less than 30% are at risk of bleeding. So we do need to use the more sensitive assay to pick up individuals, and the clot urea lysis assay is only good, again, for picking up patients with severe disease. For patients who require treatment, a therapeutic target of 15% is required as a trough level to maintain absence of bleeding, as demonstrated in the pro-RBDD, which was the prospective form of the study looking at this deficiencies. Patients with the beta subunit deficiency require use of the plasma-derived concentrate, as again, the recombinant concentrate contains only the A subunit. It's important to note in pregnancy that as the plasma volume increases, the interval for infusion needs to be shortened so that you can maintain the pregnancy with factor 13 replacement. We'll now talk about prophylaxis and prevention of bleeding. So the choice of prophylaxis is related to the frequency of bleeding, the risk of severe spontaneous bleeding, and the risk of long-term consequences related to their specific deficiency. Here we define primary prophylaxis as initiated before any bleeding occurs, which is rarely happening with rare bleeding disorders, because usually it's the bleeding that brings them to our attention. Secondary prophylaxis is initiated after a bleeding event or to prevent recurrence. Overall, the data regarding any benefit of prophylaxis in rare bleeding disorders is sparse, except in a few deficiencies. For example, primary prophylaxis is recommended in severe factor 13 deficiency from the time of diagnosis because the risk for serious bleeding events such as intracranial hemorrhage is high and leads to significant morbidity and potential mortality. Secondary prophylaxis may be considered after musculoskeletal bleeding or life-threatening hemorrhage, particularly in deficiencies of factor 10 and 13, and in severe cases of fibrinogen and factor 5 deficiencies. Indications for secondary prophylaxis, as previously stated, include fibrinogen, afibrinogenemic patients with recurrent life-threatening bleeding episodes or those undergoing surgery, patients with recurrent life-threatening bleeding and factor 10 deficiency or undergoing surgery, patients with factor 13 deficiency in severe patients due to lifelong bleeding tendency, often presenting at birth, and factor 7 deficiency for prevention of bleeding during surgery or in children with recurrent hemarthrosis or cerebral bleeding. Women with rare bleeding disorders pose specific bleeding issues and concern that require attention. Women have an increased risk of bleeding due to menstruation, pregnancy, delivery, and in the postpartum period. The risk for each of these is highlighted for each deficiency in the table. Menorrhagia occurs in about 35 to 78% in all women with rare bleeding disorders. Miscarriages are most common in afibrinogenemia, where they approach 30 to 50%, hypofibrinogenemia, 29%, dysfibrinogenemia, 38%, factor 11 deficiency, interestingly enough, 10%, and factor 13 deficiency, 50 to 63%. Bleeding with delivery, postpartum bleeding in hypofibrinogenemia, 45%, factor 5 deficiency, it's common, and factor 7, 10, 11, and 13 deficiency have high rates of bleeding with delivery. So without the use of prophylactic fibrinogen, spontaneous abortion occurs at 6 to 8 weeks of gestation. Kadir et al. Noted that only about 6 of 20 pregnancies resulted in successful live births in these individuals. The successful pregnancies were all achieved using a prophylactic fibrinogen regimen, and it's currently recommended to maintain a fibrinogen trough level of greater than 1 milligram per deciliter throughout pregnancy using a fibrinogen concentrate at a dose of 50 to 100 milligrams per kilogram twice a week. Levels, in addition, levels of less than 0.4 or 40 are inadequate to prevent hemorrhage. In addition, women with factor 13 deficiency have a high rate of spontaneous abortion, and start of prophylaxis is recommended when considering pregnancy or when pregnancy is first noted. Increasing doses or frequency of prophylaxis is required during pregnancy to maintain the desired trough level. And these pictures here can show you why fibrinogen and factor 13 are so important to maintain the pregnancy in these women, because the developing syncytial trophoblast with the placenta invading the endometrium of the uterus is dependent upon factor 13 and fibrinogen in order to maintain its viability. So treatment of women with rare bleeding disorders requires special attention and care and is based upon their age, their overall health, and their medical history, specific factor deficiency and its severity, tolerance for specific medications, procedures, or therapies that they're undergoing, effects of the condition on the patient's lifestyle, their personal opinion or preference, and taking into account cultural and social impacts to decision making. Therapeutic options include medical and surgical treatments, while management requires monitoring of the hemostatic parameters and awareness of the increased risk of bleeding with any surgical interventions or specific circumstances such as pregnancy. So let's look ahead at some new therapies on the horizon. Rare bleeding disorder space outside of hemophilia in A and B has been very limited and suffered from lack of innovation to date. However, some advances have been attempted or are in the process for specific deficiencies. For example, efforts to prolong the half-life of factor 7 and a plasma-based factor 5 concentrate have been reported. Non-factor therapies emerging in the hemophilia space may have applicability to rare bleeding disorders. Gene therapy for very rare inherited life-threatening conditions outside of bleeding disorders has been accomplished, and maybe there could be some attempts for some of these disorders, rare bleeding disorders, in the future as well. For example, Segal et al. Reported that antithrombin reduction led to an increase in thrombin generation and normalization of coagulation parameters in factor 5, 7, and 11 deficient plasma samples. So again, this is in plasma samples. And again, factor 11 deficiency is a very variable bleeding disorder. And it does have some finesse in terms of treatment. So you would really have to consider patient selection very carefully for some of these disorders. In summary, rare bleeding disorders are a very heterogeneous group of coagulation deficiencies with a wide range of clinical symptoms. Their management is mainly based on expert consensus rather than evidence-based guidelines. Replacement therapies are not uniformly available for each deficiency. For example, at this point in time, there's no specific replacement product for factor 5 deficiency where FFP is largely utilized, or for factor 2 deficiency where prothrombin complex concentrate is largely utilized. There are single factor concentrates for fibrinogen, factor 7, 10, and 11 in the EU only, and factor 13, with a recombinant product for factor 7 and 13. And again, the recombinant product for 13 is the A subunit only. There are currently no novel non-replacement therapeutics available for rare bleeding disorders, but these strategies could be an interesting approach in some specific deficiencies once their safety and efficacy has been proven with appropriate clinical trials. The next steps to go forward, there's still work to do. We need to determine the minimal dose to prevent bleeding in each single factor deficiency. We need to establish prophylactic schemes that are needed in fibrinogen, factor 5, 7, 10, and 13 deficiency. We need new strategies to improve enhanced and more sensitive assays. global partnerships for prospective data collection in rare bleeding disorders, and support provided by public health organizations for patients with rare bleeding disorders. I'd like to give special thanks to my colleague, Dr. Flora Pavandi from Milan, Italy, who has pioneered work in these disorders and really moved the field forward through her efforts. Thank you.
Thank you, ma'am, for that fantastic and lovely talk. That was great and very, very informative. Now we have some Indian colleagues who are going to bother you with the question answer session. Are you comfortable with that, ma'am?
Absolutely.
So first is Dr. Narendra Chaudhary. Your question, please.
Thank you very much for the enlightening lecture on rare bleeding disorder prevention. So one of my question is, emicizumab have been used now for factor VIII deficiency bleeding prophylaxis. So are there any studies or experience for emicizumab use in non factor VIII bleeding disorders?
There are in acquired hemophilia. There are studies going on, and it is effective in acquired hemophilia. Let me think. Actually, there was just some data. I think it's laboratory data from University of Pennsylvania looking at the use in factor IX deficiency, interestingly enough. I haven't actually looked at the data, so I'm just mentioning something I saw in passing. In individuals with factor V and VIII deficiency, a combined deficiency, if they had excessive menorrhagia that was persistent, it could be tried as an agent alone to see if it controlled the bleeding.
But because factor 10 is directed for emicizumab, so maybe it may work for other deficiencies also, not only factor VIII and factor IX. That's what I think.
I think, yeah, we'd have to kind of look at it carefully.
Yeah, okay.
Right. Thank you, Dr. Narendra Chaudhary. Dr. Kirthana Geeta, your question, please. Dr. Kirthana Geeta.
Thank you, Dr. Shapiro. It was a great informative session. I have a few queries with respect to some cases which we had come across. My first query was that whether we regularly see factor 11 deficiency associated with peri-operative situation. So as you've mentioned, it is seen similarly, but then I have encountered some literature which says that if we try to test for factor 11 during the perioperative phase, it may not give you the correct value. Is it so, or
is that because and is that looking at a specific factor 11 level versus a PTT?
Yes.
You know, I actually haven't encountered that personally. I'd be interested to see what you're referring to if you wanted to share it.
Yeah, so we had these few instances where many of these were neurosurgical cases which we came across, and they could not find any other reason for a bleed. So every time they were opening up this patient for a bleed and re-bleed, they were sending us samples, and every time factor 11 was like a borderline level. So we thought whether everything else was normal. Then I think I'll just catch up with the literature where it said that you have to test it again in the post hemorrhagic phase to get the actual value. So that was one query which I wanted to ask. Second thing is that We also have had some patients who were like VKCFD. We categorized them as VKCFD. So just wanted to know what are the therapeutic options.
For vitamin K, combined vitamin
Yes.
K. Yeah,
Yes.
it I had that on a slide. It is let me pull that. It's vitamin K, 10 milligrams IV or sub-Q, and PCC for major bleeding and FFP.
So
Yeah.
that
So
is
chronic vitamin K, high dose.
supranormal dose for okay. Just wanted to know, like, two patients which we encountered in this category were all adults. They were not children. So
And what were
both,
their level? And they weren't just vitamin K deficient, it was a persistent. Did they have
yes, they were like
yeah.
they were having minor bleeding tendencies from childhood, but it never became so severe that they would go for an evaluation. So
That's
both were
interesting.
women, both were ladies who came with this finding.
Huh.
So
Did they have any skeletal abnormalities?
yes, one of them did have. So
Yes,
she
that's
looked like
so
a marfanoid habitus. She had a marfanoid habitus, and she had been having these bleeds and all this throughout her life. And this time when she came to us, it was like she had a severe GI bleed with dysentery. She got admitted. She had antibiotics. Following that, she had severe GI bleed. Endoscopy did not show any growth. So she was around 40 years old, and she had a marfanoid habitus.
You've got some great cases. So did you treat her with high dose vitamin K?
We advised them, but we could not do the genetic analysis. So that is one drawback, that most of them we cannot enforce the genetic evaluation.
Very interesting.
And just one more last query.
I am interested in that factor 11 and during surgery, because it's not an acute phase reactant. I mean, I wonder if it gets activated in some way through the process. It's interesting, and you get a false reading.
Yeah, this was if I come across literature once again, I'll share it with you, madam.
Yeah, I wonder if the patient got any treatment at all.
No, I don't think, because we also could not suggest a definite thing. We could just give a descriptive sort of a report, because we could not confirm or be sure of the finding.
Yeah, because
So
when I think back to some of our 11 patients who have had acute bleeding, their 11 level was the same.
also just one last query, that how do we come to deciding whether the bleeding is due to an abnormality in the fibrinolytic system? So most of the times we end up testing all the coagulation part, and then we don't find anything, but still we know that the patient has a bleeding issue.
Right. So those are hard ones. I think, the euglobulin lysis time can be helpful, especially when it's short. So if you can look for a shortened euglobulin lysis time with excessive fibrinolysis, that can be helpful. And I was speaking to one of your colleagues, Dr. Tetsu Urano from Japan, is trying to develop more sensitive assays in the fibrinolytic system, especially for Pi1 deficiency, where the assays are not very good, to try to look at some of these parameters. It's hard. It's, like you throw them in some category, or their bleeding disorder of unknown cause. And we had a family with East Texas bleeding disorder, which is autosomal dominant, which we couldn't classify for many, many years, until one of my colleagues who has a special interest in that area was able to do the assay and looked at it and found that that's what it was. And there's multiple generations of that family here. Yes, and Teg and Rotem. Yeah. to look at hyperfibrinolysis.
But then we don't have a level to work on.
Yes, I know, it's a general assay. It gives you an idea, and then you can look at, you know, alpha-2 antiplasmin, you can look at some things, but you can't look at all of them. Genetic
Just
analysis is
I'm
helpful.
reminded of one more case where we had this lady with factor 13 deficiency. So we had put her on, I think, FFP prophylaxis. So it was like she started to bleed at the nick of the 2 weeks, and so we were not able to decide when to exactly tailor this. So even though the literature,
actually, if your cryoprecipitate can be used for those patients and can be easier to use than the FFP for factor 13 if you don't have the concentrate available.
Right.
Has a higher
Thank you.
concentration and you can get a bigger volume in.
Thank you, Dr. Geeta. Dr. Kapil Garg, sir, your question, please.
A very informative talk, madam. My question is, just now you mentioned that you had read about some data of emicizumab in factor 9 deficiency. So can you elaborate on that? Because as far as I remember, emicizumab is being used for only factor 8 deficiency.
Yes, it is only being used for factor 8. I think this was some laboratory work, and I just saw it in very passing from Dr. Samuelson in Philadelphia. So I haven't pulled the reference or the data yet to look at it. So I'm not recommending this at all.
Okay. And my second question is, recently I had a patient. She was a girl child and she had APTT of 70 seconds with factor 8 levels of 3%. And his brother also had similar presentation. He also had prolonged APTT and low factor 8 values. And their von Willebrand panel was absolutely normal, but they had slight aggregation defect when bleeding time was checked. So how to proceed further for these patients?
Well, these are males or a female and a male?
Male and female both. Brother and sister both had APTT values of 60 to 70 seconds and factor 8 values of 3%, 4%. And
Did you
von
look at
Willebrand
their
panel was normal.
Did you look at their factor 5 levels?
No, I didn't.
I would. Because it could be a combined 5 and 8 deficiency.
Okay, but why would aggregation defect be there in combined factor 8 and 5 deficiency? Because
Factor 5's in the platelets too.
okay, so that can lead to aggregation defects.
I haven't actually looked at aggregation in those patients, but
Okay.
I would look at the 5 level. Let me know what you find.
Okay, sure. Thank you.
Thank you, Dr. Kapil Garg, sir. Dr. Yogalakshmi, your question, please.
Thank you for the excellent lecture, ma'am. Actually, we have one factor 11 deficiency diagnosed in a primate, a 32-year-old primate who never has a history of bleed. Just because of the prolonged APTT that was diagnosed, and she was about to go to elective cesarean section for her delivery. So how to manage during this perioperative period?
And has she had any surgery before?
No, ma'am. She has never had a dental extraction. She has never had a surgery before. And there is no history of spontaneous bleeding from anywhere else.
Okay.
So even heavy menstrual bleed, she's not complaining. So how to manage during the perioperative period?
And she's having a cesarean section, you said?
Yeah, elective cesarean.
And is this her first baby?
Yes, this is the first baby. She's the primate.
Okay. And why is she having a C-section?
For the floating head, actually, at term.
Okay. Is she gonna, okay. So, I think probably one of the world's experts on this is Dr. Ophira Solomon from Israel. You could start with antifibrinolytics on this patient. You could use very low doses of 7A, one dose, 10 to 15 micrograms per kilogram, and then watch the patient.
Okay. Prophylactic FFP transfusion is not advised in these patients.
You can do that as well.
Okay.
It's not, you know, it's got a lot of volume associated with it, and I mean, it's possible you could use that as well.
Okay, ma'am.
Yeah.
And one more question. Actually, it's not a bleeding disorder as such, but a patient was diagnosed with a protein S deficiency when she was evaluated for repeated pregnancy loss. So they have done an NGS which doesn't show any mutations in protein S gene as such. But protein S levels were low, and she came during her fourth pregnancy. She had 2 abortions before and one second trimester loss, and she came for fourth pregnancy, where she was started already on aspirin and clexane, that is low molecular weight heparin, and then now she's having some spotting PV. As far as I went through the literature, protein S deficiency, protein S levels in pregnancy is not, it can get lowered, and there is no specific cutoff to say whether it is really deficient or not. So how to manage in these cases of disorders?
That's so. Have you only got her protein S levels during pregnancy and not before?
No, protein S levels before pregnancy were low, but protein S levels during pregnancy has come down more lower than the previous levels, non-pregnant levels. But there was no specific cutoff to say whether it is really low in pregnancy or not.
So how low is it when she's not pregnant?
When she was not pregnant, it was 32%. And when she was pregnant, it was 23%.
And she has a history of thrombosis as well beyond the pregnancy loss?
No, she doesn't have any history of thrombosis. The only thing she got evaluated was for bad obstetric history.
Well, that's a hard one. And so now she's having spotting on low molecular weight heparin, you said? And
yes,
is she on she's on therapeutic dose?
Yes, sir. Yes. Not on therapeutic dose. She's on prophylactic dose.
Prophylactic dose. And how far along is she in the pregnancy?
She's now in the first trimester. She's around say 9 weeks, like that.
Well, and she's lost pregnancies before.
Yeah, she has lost 2 pregnancies, spontaneous abortions, and 1 second trimester loss. The cause is actually not known why the second trimester loss was there.
Yeah. So you said she's on prophylactic low molecular weight heparin and aspirin.
And aspirin, yes, ma'am.
Yeah. I mean, I suppose you could back down a little bit on the aspirin.
Okay. We can reduce the dose of aspirin, or we have to stop it altogether. She's on 150 mg.
Well, it's got a half-life, you know, for 2 weeks, essentially. I might half the dose and see what happens. Go to every other day or half the dose.
Okay, ma'am. And to continue with low molecular weight heparin.
I'm just, this is a hard one. I'd have to look up her whole workup and her history, but that's my best guess. I mean, I don't think prophylactic low molecular weight heparin should do this. I think it may be related to the aspirin more.
Okay, ma'am.
Okay,
ma'am. Thank you.
Thank you, Dr. Yogalakshmi. Ma'am, we have some couple of questions from the audience. Dr. Yimon Tent wants to know, when you suspect rare bleeding disorders, what would be your sequence of order for screening each factor deficiency in your usual approach?
Well, that's hard. So the first thing is, you have to look at the PT-PTT and see if they're prolonged. And obviously, then and I also do fibrinogen and thrombin time, looking at assays for those. And then you can look at most of the, coagulate, 5, 7, 10. Now, factor 5, you can actually have a normal PT with a decreased factor 5 level. So in the face of normal levels, you can also have a decreased factor 9 activity with a normal PTT. So if all of those screening tests are normal, then I start looking at specific factor assays. So for example, I would look at a factor 5 and I would look at a factor 9 specifically, because they can be masked with a normal PT-PTT. I start looking at the rare ones that aren't picked up by the screening assays, such as factor 13 deficiency, alpha-2 antiplasmin, and then start working down the list. Usually what I look at are the patient's symptoms and the inheritance within the family, because that can give you a clue as well.
Thank you so much, ma'am. Another question from Dr. Bipin Kulkarni. In our countries where, low socioeconomic countries where these tests are not available to diagnose these fibrinolytic defects, like you said about test, can we just go for TAG or ROTEM for them? Well, whether TAG or ROTEM can tell us that this can be a fibrinolytic defect, only that is more than sufficient?
If it's all you have, it's all you have. And I guess what I would do is try to find some colleagues near you, for example, in other countries that have specific interests in fibrinolytic disorders, to send samples to do more advanced testing, if at all possible.
So as per according to our experience, like these two cases that I spoke to you earlier about, those two alpha-2 antiplasmin, we could find homozygous mutations in these families, but surprisingly, they were not picked up by the TAG. That time we did not have ROTEM. Now TAG has to be either made a little bit more sensitive, or now I have the ROTEM, but I have to call back those families. I don't have access to those families again. But I would love to run them on ROTEM and see if ROTEM picks them up effectively. So that was the dilemma. I might have, we might miss many cases of possible fibrinolytic defects if you are running only TAG. I'm not sure.
I agree. It's supposed to pick up some of these patients.
Yeah.
There are some ways to make it more sensitive to some of these defects, but it requires manipulation and testing of the assay. So it's just not optimal for saying that's what you have or not have.
Right. So these two cases, on high suspicion, we sequenced these two cases and we found the homozygous mutations, and we did the family studies and it was confirmed. But on TAG alone, we would have missed it.
That's good data. Can you do an alpha-2 antiplasmin assay?
We did later on, and we found a deficiency. It was not absolutely absent, but it was reduced
very low,
quite a lot.
Yeah. So I usually look at the assay. If
we did.
Yeah,
eventually
if the
we did.
Is, stone cold normal, I'll do an alpha-2 antiplasmin.
Right. Thank you.
Thank you, ma'am. Thank you, Dr. Bipin. Another question is, if the patient has got combined factor 5 and factor 8 deficiency, posted for dental extraction surgery, how would you manage this patient?
What kind of dental extractions? Roots, no roots, wisdom teeth, operative, what?
Root canal surgery.
Root canal?
Yeah.
That's not so bad. I think I'd use DDAVP and an antifibrinolytic and try to get away with no 5 replacement if possible.
And if it is dental extraction, then tooth
Well, if it's
extraction.
a wisdom tooth, and you're pulling something, you're really pulling something out, you might need some factor 5 for that, some FFP. But you can try, with DDAVP and an antifibrinolytic, but might be hard.
Thank
If you
you,
had
ma'am.
really good hemostasis, local hemostasis.
Thank you, ma'am.
Good
If the
dent.
another question is, if the patient is presenting to you with a recurrent miscarriages, it is must that we screen them for even factor 11 deficiency in all such cases?
No, usually I look for other acquired abnormalities, antiphospholipid antibodies and other things. I don't think it's as common. It can happen, but
Well, so I've finished all the questions from the audience. Any discussion want to ask any other question?
you guys ask hard questions.
Yes, ma'am. So there are no more raising signs and no more questions from the chat box. I've finished all the questions from the audience. Well, ma'am, thank you so much for that fantastic and lovely lecture. That was great, very, very informative, and a wonderful question answer session.
Well,
Thank you so much for being with us today. It was nice to have you today. Evening for us and morning for you. Thank you. I thank all our discussants to participate in this webinar and meet you tomorrow with another beautiful webinar at sharp 11:30 a.m. Sunday morning. Goodbye for
And
now.
Dr. Kulkarni, you'll send me your email address and I'll connect
Yeah,
you
sure.
to Dr.
Yeah, I
Tibbs.
would love to. Sure. I
Yeah.
will connect with you. Thank you so
Okay.
much. It was
You're
great
welcome.
meeting you. Yeah.
Nice to meet you. Bye-bye.
Bye.
Thank you. Good day.